Welcome to your online lecture for Chapter 9, which is entitled Automated External Defibrillation in your textbook. As you will recall from Chapter 8, early defibrillation is a part of the chain of survival. To get defibrillation to patients early enough, as many trained people as possible, not just physicians and paramedics, must be able to perform this life-saving skill. Automated external defibrillators, AEDs, as I'm going to refer to them from here on out, have made that possible. And so now first responders, EMTs, and other members of the community can defibrillate a patient when it is needed because it's such an easy task to do. And it can really be the difference between saving a patient's life and a patient dying in an emergency situation when they are suffering from cardiac arrest. And so we're going to talk about the process of applying an AED and when it is necessary to do so within an emergency situation. So in Chapter 8, we talked extensively about cardiovascular disease, and one of the questions that I always pose is it an epidemic when we know that 350,000 people within the United States suffer from or die from cardiac arrest? It poses the question of whether or not this is actually, this disease is truly an epidemic within the United States. And so what we learned from Chapter 8 is that CPR is effective at both circulating blood, but also getting in oxygen to the body. And with the combination of ventilations and respirations, what we know is that CPR is effective at truly circulating oxygenated blood to the rest of the body to hopefully supply the dying tissue cells with some type of oxygen, right? To delay that death or to reduce the death of the cells supplying the tissues. However, what happens when we have a patient in cardiac arrest who actually has a dysfunction within the heart's electrical system? And in that case, there's nothing that we could do as it relates to CPR to restart the heart's electrical system. And so that's where the automated external defibrillator will come in an emergency situation. So normally with a healthy heart, what we tend to see is this electrical impulse being sent to the heart, and when the electrical impulse reaches the anatomical structure in the heart, it causes the heart to beat or to contract, to push blood out to the rest of the body. However, in a patient who is suffering from some abnormality within the heart's electrical system, what we tend to see is the electrical signal traveling. However, it is not allowed to reach the heart, and as a result, there is no electricity being applied to the heart, and the heart isn't allowed to either beat or pump blood effectively and efficiently to the rest of the body. And so, as we talked about in Chapter 8, when the heart isn't allowed to pump as effectively, what that essentially means for our patients is that they're getting less oxygenated blood to the heart, specifically to the brain, and to the muscular tissue as well. And this poses a problem because in the heart, the myocardiocytes begin to die off. In the brain cells begin to die. And what we know about the brain is that if we don't provide adequate treatment to our patients within that 0 to 4 minute time frame, then again, we're concerned about brain death in our patients. So what is automated external defibrillation? So if we were to define defibrillation just by itself, what we would say is that defibrillation is this process by which an electrical shock is applied to the patient's chest, right? And this patient must be in cardiac arrest. And so remember we said that cardiac arrest equals a patient who has no heartbeat and is not breathing, right? And so we said, okay, a patient who has no heartbeat and is not breathing needs us to simulate both of these functions in order to survive. And so what an AED is, or what defibrillation is really this electrical shock that's going to be delivered to this patient in cardiac arrest, a patient who is unresponsive, is not breathing, and does not have a pulse. And it's applied to the patient's chest in order to basically correct the fatal heart rhythm that is responsible for the cardiac arrest itself. Just like with the clock for breathing, where we talk about the 0 to 4 minute time frame and not breathing in oxygen into the body and brain death, the same thing applies for a heart that is not beating. What we know is that for each minute that the heart has stopped, significantly reduces the patient's chances of survival. And what they say is for every minute that the AED is delayed, it reduces the patient's chances of living by 10%. So let's say it takes us 4 minutes, to get the AED to the scene. That'd be reduce the patient's chances of survival by 50%. So we can kind of see that the AED plays a major role in the success rates of patients who are suffering from cardiac arrest. So it becomes important to not only know what defibrillation is, but also to recognize where your automated external defibrillators might be within the building that you're working in, within the environment that you encounter the emergency situation, so that you might have early access to the defibrillator. So when we talked about heart anatomy, we said that the heart was composed of 4 chambers. One of those chambers was the right atrium. The second chamber was the left atrium. The third chamber was the right ventricle. And then the last chamber was the left ventricle. And we kind of said when blood was allowed to flow into the left atrium, that we eventually had some type of contraction, and that contraction then forced blood out to the rest of the body through the aorta to supply tissues with oxygenated blood. And so now what we're going to talk about is how blood is allowed to flow and what stimulates blood flow, and that's the heart's electrical system. And so we kind of have to start with the sinus node first, or as some people know it, the sinoatrial node. Some people also refer to this as the heart's natural pacemaker. So the sinoatrial node is a bundle of special cells, which we kind of see right in here and also right in here, located within the right atrium. And these special cells are responsible for creating electrical signals that kind of trigger the heart to beat. Again, it's also known as the heart, or as the heart's natural pacemaker. And then from there, what we see with the electrical signal is that it travels from the sinoatrial node in the right atrium to the atrioventricular node. And the atrioventricular node, once it receives the electrical input from the sinoatrial node, then kind of sends a signal down to the bundle of his fibers, or what we would call the Purkinje fibers. And so when we think about the heart's electrical system, we have electrical impulses being generated with the sinoatrial node. Again, the sinoatrial node is a bundle of special cells that are responsible for generating electrical signals that trigger the heart to beat. Electrical signals then travel from the SA node here, here, and here into the atrioventricular node, which is also a bundle of special cells. But this node known as the AV node is located halfway in between the atria and the ventricles. And the reason that this AV node is important is because it is responsible for then delivering that electrical signal to the bundle of his. And why is the bundle of his important? Well, there are several reasons for that, and we're going to talk about that. As the electrical impulse leaves the atrioventricular node and is transported down into the Purkinje fibers, or the bundle of his, it is at this point that the bundle of his and the Purkinje fibers, which are really located within each of the ventricles, gets stimulated. And we can imagine that, as we see here with all of the bundles or the fibers that are laying within the ventricles themselves, what we can see is that when an electrical signal gets transported to the Purkinje fibers, that this is what causes the ventricles to contract. And so once the Purkinje fibers become stimulated, the ventricles are allowed to contract. And as we can imagine, this would be the equivalent of the heart contracting enough to pump blood throughout the rest of the body. So it might be that in our cardiac arrest patients, that either the electrical signal isn't being transferred from the AV node to the Purkinje fibers, because of this, the Purkinje fibers do not cause the ventricles to contract, and because they do not cause the ventricles to contract, our patient isn't getting enough oxygenated blood throughout the rest of the body. And so what we have is a situation where not only will the ventilations and the chest compressions be effective, but we need something to jumpstart the sinoatrial node. We need something to get that special bundle of nerves to generate an electrical impulse, and that something is the automated external defibrillator. So because the sinoatrial node elicits or generates an electrical impulse that travels to the atrioventricular node and then down to the Purkinje fibers to stimulate the ventricles in particular to contract and pump blood to the rest of the body, what we can then say is that at some point in time, we have to have contraction and we have to have relaxation as well. And so the contraction would really be that point in time when the ventricles are contracting and blood is being circulated to the rest of the body. And then we could say that the relaxation state represents that represents that time for the ventricles to refill, to recuperate in order to supply blood to the rest of the body again when they get ready to contract. And so one of the tools that's used to detect deficiencies in heart rhythm is what's called an electrocardiograph. And so we can kind of see in the figure to the right, which is located over here, that we have an electrocardiograph. And so what we're going to learn today really is how to interpret that and what the P, Q, R, S, and the T actually represent and what they mean. So the first wave of the electrocardiograph is the P wave, and the P wave represents the spread of the electrical impulse through the atrial musculature. Another way stated is really what we're saying is that it is a representation of the sinoatrial node's ability to generate some type of electrical impulse, right? Because that electrical impulse has to travel down to the atrioventricular node. And so we would say that the P wave represents the sinoatrial node's ability to generate electrical impulse and for that electrical impulse to travel through the atria. So the next portion of the electrocardiograph that needs interpretation, and probably the most important portion of the electrocardiograph, is honestly the PQ or the QRS wave. And what the QRS wave represents is the spread of the electrical impulse through the ventricles, right? And so, or we could see it another way, it's the transmission of electricity from the atrioventricular node to the Purkinje fibers, which again are going to cause the ventricles to contract, right? And if for example, that QRS wave is high, then we know that potentially we've had a great contraction from our ventricles, and they are capable of efficiently pumping blood throughout the rest of the body. However, if that QRS wave is very low, then what we say is that wasn't a strong ventricular contraction. And so the QRS is really where we want to focus when we are assessing electrocardiographs. Again, this is outside of the scope of athletic training and the practice of athletic training. And so this graph or gram, either way you look at it, would probably need to be interpreted by a physician. And last but not least on the electrocardiograph is the T wave, and the T wave represents that point in time when the ventricles are at rest, so ventricular rest. And this is the time, again, where I said the ventricles are allowed to do what? They're allowed to refill, right, and get ready for the next contraction to pump blood to the rest of the body. So all in all, what we could say about the electrocardiograph is that it tells us a lot about the characteristics of our patient's contractions in terms of their heart. Are they able to efficiently, are the ventricles able to efficiently contract to supply the body with enough oxygenated blood, or are they not contracting strong enough? And in that case, we become concerned because there's a lack of blood, a lack of oxygen to our tissues, and our cells begin to die, in particular our brain cells and the myocardiocytes within the actual heart itself. So there are two types of abnormal heart rhythms that you will encounter in an emergency situation. The first one that we'll talk about is ventricular fibrillation. And so if we look at this electrocardiograph to the right, what you will see is, of course, the normal heart rhythm of a normal patient. And so we can clearly identify, specifically if we're looking at one heartbeat, we can identify the anatomical structures of the wave. And so we could say that this is P, this is Q down here. We could say this is R, this is definitely S, and this is definitely T. And so when we look at this chart here, we can't identify those anatomical structures within the electrocardiograph. Specifically, we can't identify Q, R, and S. And remember what we said is that Q, R, and S really represents the traveling of the electrical impulse from the atrioventricular node down into the Purkinje fibers. And the Purkinje fibers, again, are responsible for causing ventricular contraction. And so what we get with a patient who's in a state of ventricular fibrillation really is this chaotic, unorganized heart rhythm that is not capable of producing or creating a pulse or circulating enough blood to create or to sustain life. And so again, with fibrillation, there's this quivering of the ventricles. The ventricles are in a state of hypercontraction, and because they're constantly contracted, they cannot refill. Therefore, they cannot circulate enough blood to the rest of the body to sustain life for our patients. So it is these patients, the patients that have no pulse, because the ventricles just aren't contracting, blood flow isn't going to the body, and they are pretty much lifeless. It is these individuals that we want to defibrillate, right? And so that's where the AED kind of gets its name. It's meant to help a patient who is in a state of ventricular fibrillation. On the opposite end of that spectrum, what we also have in terms of abnormal heart rhythms is an abnormal heart rhythm known as ventricular tachycardia. And so when we think of someone in a state of ventricular tachycardia, what we think of is someone who has a rapid heartbeat. And so again, I draw your attention to the right side of the screen when we're looking at this figure. And again, of course, we have the normal echocardiograph here, and we can see the QRS perfectly. However, when we look at a patient with ventricular tachycardia, some of these structures are a little bit more identifiable than a patient with ventricular fibrillation, where we can't identify any of the structures of the wave. And so we might say, okay, this is an upside down QRS. We might be able to see the T portion of the wave here, but overall it's this state of disorganized rapid contraction of the ventricles. And so the rate is so fast that the heart is unable to pump blood properly. So here's the deal with ventricular tachycardia. We could say that this rhythm is more organized than fibrillation. However, it's very rapid, and it's still an inefficient way to move blood to the rest of the body. Here's the other differential with tachycardia patients compared to patients who are in what we would call VFib, and that is that patients who have tachycardia still have a pulse. And so when we use an AED should only be used on patients who do not have a pulse, and that would be a patient who's in a state of ventricular fibrillation and not tachycardia. So what is an AED, or an automated external defibrillator? It is a device that has a microprocessor that actually is capable of interpreting heart rhythms just like a physician or a paramedic would. When necessary, an AED is going to deliver a shock directly to the patient by way of adhesive pads, and you'll see those in the next slide. I think that what you need to know about an AED is it's an automatic device. It's designed so that a person arriving at the scene with a 5th grade learning level could actually apply this device and make it work and use it successfully. So I have no doubt that you as college students would be capable of turning on an AED and hooking it up to your patient and using it like it should be used in an emergency situation. The pads that you apply to your patient are connected to the AED through cables, and these cables transmit a shock to the patient's chest, powerful enough to correct a lethal heart rhythm such as ventricular fibrillation. And so it's important that your pads have good adhesive so that they make good contact with your patient. The pads are truly what makes defibrillation safe, since no one needs to touch the patient at all during analysis or shocks. Once the pads are applied to your patient, they're adhesed to your patient's chest. The first responder does not have to hold it. And so in the olden days, you had these little wooden paddles that the first responder would have to hold. And sometimes that electrical impulse was not only transmitted to the patient, but also to the first responder. Now these sophisticated AED devices really have pads that connect to the AED, and it requires a hands-off approach, which means less first responders receiving shocks in the field. So good kudos for you, right? So there are several steps that we would take in order to use an AED. The big one is to confirm that your patient is in cardiac arrest. The number one and number two signs that a patient is cardiac arrest is there is no pulse, so no signs of circulation, and there is no breathing, or what we would say no signs of respiration, right? These two things have to be present in order to apply or to use an AED in an emergency situation. And then after that, it's really a step-by-step process. The device will tell you exactly what to do, and we'll practice this in lab. But you're going to turn on the AED. If your patient has on some type of shirt, you're going to cut the shirt off of your patient so that the patient's chest is exposed. Obviously, with female patients, we kind of want to take off the shirt, but then maybe after we have the AED on, apply a blanket just to protect our patient's privacy. We're going to attach the AED electrodes. We're going to turn on the AED, and we're going to let it analyze our patient's heart rhythm. Again, going back to that logarithm, if the AED does think that the patient needs to be shocked, it'll deliver a shock and will begin CPR for 2 more minutes, and it will reanalyze the rhythm. There are times in the field when the AED might determine that a shock isn't necessary. In that case, continue CPR for 2 minutes and allow the AED to reanalyze the patient's heart rhythm after 2 minutes of CPR treatment. So when we think about setting up the AED, there are several different pads that are currently being sold on the market, and there are 2 types that I present here. The attached pads, so pads that are actually attached to one another via some type of conduit, right? Something that they're stuck to. It makes it very easy to put the pads in the right spot. These are a little bit more expensive in nature because they are easier to apply to our patient, and they also last for a longer duration. Whereas these other pads, which are individualized, as you can tell here, and are stuck to some non-adhesive backing, you peel them off and you apply them to your patient accordingly. I always use the acronym that white goes on upper right. So the white pad is always going to go on the upper right shoulder of our patient, and you can kind of see that positioning here. And then the red pad or the other pad goes on the lower left nipple or just underneath the breastplate of the patient. And so we can kind of see the AED pad set up there. And once again, we'll do this in lab. And so the number of shocks delivered and the energy at which they are delivered is determined by the manufacturer. Okay, so every manufacturer for every AED device has different preset number of shocks and energy. So when you're shopping for an AED for, like, let's say your athletic training room or your physical therapy clinic, you need to look, do some research to determine the amount of energy and the number of shocks that your AED will actually deliver. All AEDs typically have the same prompts, and the batteries are pretty expensive to replace, so always make sure that the AED is in the offsetting unless you absolutely need to use it. So for a child, the pad setup is a little bit different, and most of the time the reason it's different is because the pads are so big on a child and or an infant that they actually touch. And one of the contraindications for utilizing an AED is that the pads do not touch. So if the pads are so big that they're touching on your patient, specifically a child or an infant, one of the recommendations is to put one pad in the anterior portion of the chest on the sternum, and then the other pad on the posterior portion right between the scapulae, or what you guys would know as the shoulder blades. And we can kind of see this patient position. This way it ensures that the electrical impulse is being sent to our patient, and that our pads are not touching. When the pads touch, it tends to interfere with the AED's ability to assess the electrical activity in the heart, and so this pad setup is the recommendation. So there are some special situations that we need to take into consideration. One of them is our patients with pacemakers. We never ever want to place a pad directly over a pacemaker, so you might have to adjust your pad. Your pad position might have to be a little bit lower or a little bit higher depending on the positioning of the pacemaker, but never ever put a pad directly over a pacemaker. So once you bare the patient's chest, go ahead and sweep the patient's left side to determine whether or not there's a pacemaker, and if there is, then again, we do not place the pad directly over the pacemaker itself. In hypothermic patients, so patients who have, let's say, fallen into an icy lake, because we will encounter them in Point Loma, especially in the winter times when we have surfers, the big deal is that we have to dry the body off. Now let's think about that. If we have a wet body and we apply electricity, what do you think could happen? Well, we could electrocute our patient, right? And so if we have a patient with wet clothing, what we have to do is we have to actually remove the clothing from our patient. And then once we remove the clothing from the patient, we have to completely dry the patient off before we can actually apply the AED. For trauma patients, we want to save a life, and so we at this point in time in the emergency situation, we're really not concerned with if we're going to make the trauma worse. What we're concerned about is saving a life, and so an AED still can be used. In the past, it was thought that you couldn't use an AED over jewelry or with a patient wearing jewelry, but now you do not have to remove jewelry. In fact, jewelry does not interfere with the electrical impulse or the electrical activity of the AED and its ability to read the heart's electrical activity. So you do not have to remove the patient's jewelry. So some precautions to consider when using an AED. Some of the big things are, number one, you don't want to use alcohol pads. Why? The biggest reason is because when the electricity hits the skin, if the alcohol hasn't dried, it could actually cause burns on your patient. You never want to use an AED in a moving vehicle. The biggest reason is because it may not be able to analyze the heart's rhythm because you get movement, and that interferes with the AED's ability to interpret the heart's electrical activity. Again, going back to a victim in water, well, the big deal is electrocution, right? Do not use an AED on a victim or a patient who is less than 8 years of age or below 55 pounds because the electrical impulse being delivered could be enough to actually cause damage to our victims. We also do not want to apply an AED over a nitroglycerin patch, again, because it's wet and the AED electrical impulse could actually cause some type of burn over the nitroglycerin patch itself. One of the big deals is just to remove the patch, to dry the area, and then to apply the AED. In terms of not using AED within 10 feet of a cell phone, big deal is the electrical signals might cross, and again, you might either get a false positive and or a false negative reading from the AEDs. So these are some of the precautions. Obviously, there are others depending on the emergency situation. So we kind of have to use common sense when we're applying an AED to an unconscious patient who is in cardiac arrest. What I will say is that, in summary, what we do know is that when the heart stops beating, eventually breathing ceases, right? And so when breathing ceases, when the heart stops beating and we no longer have a pulse, we have to start CPR ASAP. If we do not start CPR ASAP, remember the patient doesn't get oxygenated blood. Because they don't get oxygenated blood, the brain and the heart cells begin to die off, and we lose the ability to pump blood to the rest of our body as effectively. For every minute that the AED is delayed, remember that reduces the patient's chances of survival by about 10%. And so when we have no breathing and we have no heartbeat, then we need to start CPR immediately. Thank you for listening to this online lecture on Chapter 9. We will begin next class session with a lab on rescue breathing, CPR, oxygen administration, and AED administration. So please be prepared. Please know your ratios for CPR. Please know your ratios for rescue breathing. And please review Chapters 6 through 9 in terms of their online lectures. I look forward to seeing you in class. Have a wonderful day.